This is the first grand round of Michaelmas term. For those of you who don't know me, I'm Dom Furness. I'm a plastic surgeon, professor of plastic and reconstructive surgery. And up until about 2.5 weeks ago, I was head of School of Surgery as well for the Thames Valley region. I've just passed that on to James Ramsden, who's an ENT surgeon. But I was asked to chair this grand round, which is on some very difficult topics, because I've been part of the Thames Valley working group. And while I was head of school, that was one of the most important pieces of work that I was doing to try to work out ways that we can stop harassment, bullying, sexual harassment within surgery in the Thames Valley, and then hopefully apply those lessons more broadly. And May is going to tell us much more about that and about the work that she's been doing on a national level. So just to introduce her, May Nortley, most of you will know, consultant vascular surgeon here at OUH. She's Deputy Director for Undergraduate Surgical Teaching in the university and within NDS. And she's co-lead of the Thames Valley Working Group for Sexual Misconduct. And she's also a member of the Royal College of Surgeons of England Sexual Misconduct Working Group. So she'll be speaking to us about sexual harassment in healthcare. Thanks, Mike.
So I don't know if you can hear me, but first of all, thank you so much to all of you for making the effort to come to the Richard Doll's first grand round in Richard Doll. I appreciate it's a new venue, so really appreciate the effort. Firstly, this presentation does contain some challenging content, so I won't be at all offended if anyone just leaves the room. That's absolutely fine, and usually there is silence, so that's okay as well. So I just want to start by asking you, how many of you have children in this room? Or how many of you have a sibling or a niece or a nephew, or a young person who is aspiring towards something, working really hard towards, for instance, entering a career or having an aspiration or nearing university or college, and they'll be entering the workplace in the next 5 years. And I want you to keep that individual at the forefront of your mind as we go through this presentation. Because what we're about to discuss is a problem that not just pervades surgery or healthcare, but it pervades throughout every profession, and it pervades through society. So to start with, this was a publication written by Darrell, my colleague in the university, and her group from the Working Party of Sexual Misconduct and Surgery. And it really showed for the first time what we probably all anecdotally know, but still the statistics were shocking. And that showed that for the surgical workforce, they were asked to report on events that had happened in the last 5 years. So we're not talking historical data, we're talking recent current data. And that showed that in women, 63% reported sexual harassment, 30% reported experiencing sexual assault, and 11% experienced forced physical contact for career opportunities. And the statistics were not insignificant for men either. 24% of men reported sexual harassment, 7% assault, and just under 1% forced physical contact for career opportunities. And the harsh reality is that essentially everyone, 90% of women and 81% of men, reported having witnessed sexual harassment. So we know that this is everywhere. This is the first time that this had been documented and statistically proven and published. So human nature is that we look at those statistics and they're pretty shocking, and we kind of tend to just reassure ourselves that actually yes, it's saying that it happens everywhere and it's saying that it's happening in our profession, but we tend to kind of tell ourselves actually it's happening in other units or other departments, or this is not my institution, this is other institutions. But then there was this publication, which I did jointly with the Royal College of Surgeons in the Bulletin. And actually, I asked 6 female colleagues that were current colleagues if they would be willing to give me examples of sexual harassment they had experienced recently. And within 2 hours, I had 35 examples messaged to me, and these are some of them. And I think it's pretty shocking to read these in a professional setting. This is a surgical grand round. We're all sitting amongst our colleagues. And these examples, I'm sure you agree, are explicit, they're shocking, they're upsetting, and they are degrading. And if we are feeling shocked about reading them while sitting amongst our colleagues, imagine how shocked and degraded you feel if you turn up to work as a young person who has worked really hard, is highly educated and highly trained, and you're expecting to come to work as a professional and be treated as a professional, if someone you look up to then says this to you. And uncomfortable though it is, I want you to imagine these things being said to that young person that you just thought of. After all, the other thing that we tell ourselves is that it's just words, right? No one has actually been physically harmed by those words. They are just words. But is misogyny and banter relevant? Well, this is the rape pyramid. And for me, this was a pivotal moment of learning for me as I started doing this work. And all of those comments contribute to the bottom layer of this pyramid. So they contribute to a foundation of attitudes that devalue and dehumanize, usually women, not always women. So things like locker room banter, talking about sex at work, objectifying your colleagues, making gender stereotypical comments about women or effeminate people, or it devalues and dehumanizes a population. And it also feeds into a narrative of power, control, ownership, and entitlement. And all of those beliefs justify and validate the behaviors as we move towards the top of this pyramid. So touching, groping, and you can see as you go to the top of the pyramid, if you have a sense of control and entitlement, things like, well, I spent £100 buying her drinks all night. How dare she not sleep with me? And can turn into rape. And as that entitlement turns into rage, you can see how cases of murder happen related to this rape pyramid. And so by tolerating these comments, we enable harm. And that's borne out in the headlines that we see about doctors. So this doctor said he was emboldened by the banter culture at work. He felt validated and supported by his behavior in his behaviors, and he felt that his behavior was aligned to the attitudes of his colleagues. And so we think about that power, control, ownership, entitlement, and that rape pyramid, and it suddenly becomes clear. If we didn't truly believe as a society that women were of less value than men, then we wouldn't have a gender pay gap. But we know that a gender pay gap occurs in all areas of our society, be it finance, media, journalism, absolutely healthcare. And actually, globally, women on average are paid 16% less than men. And then we look forward at cases such as the Giselle Pellico case, where her husband drugged her and offered her out to over 50 men in the community. And their justification, many of the times, their justification was that actually her husband gave me permission to do this. So again, power, control, ownership, entitlement. Mohammed El Fayed, owner of Harrods, a powerful businessman with many assets. The women he employed were perhaps assets, and perhaps therefore he was entitled to do whatever he wanted to them. And most chillingly for us, the case in the middle, the Oxford transplant surgeon who sexually harassed for over a decade multiple targets. And he always made sure that he was their educational supervisor. So again, power, control, ownership, and entitlement. And so I think suddenly our understanding becomes very clear. And it's clear that we as a community, as a healthcare community, we have a choice. We can choose to either destabilize this foundation of attitudes, or we can choose to maintain them. Or we can choose to disable the beliefs that validate harmful behaviors, or we can keep quiet and we can enable them. So I personally have had to do a lot of self-appraisal over the last few years since I started this work, and that's how it's going to start for all of us. We all have to start appraising ourselves. And the first thing I'm going to mention is conflicts of interest. These come up all the time in these scenarios. So a very common conflict of interest is perhaps you are the senior lead of an academic group and your most productive researcher, the prolific person in your group, perhaps is harassing the most junior member of your group. What are you going to do? Because if you do something about it, your research output is going to plummet. And that represents a very real conflict of interest that happens all the time. And the same on the clinical side. Maybe your clinical director treats you really well, takes care of you with your job plan, but they are harassing another member of your team. But you're going to keep quiet because actually your interests are protected. So until we start recognizing our own conflicts of interests, we're not going to be able to do anything about it. We have to be honest with ourselves about our own conflicts. I'm going to talk about normalization, definitions, and bias. So normalization, there was another population of female surgeons that I spoke to, and I said, have you ever experienced sexual harassment? And a lot of them said, no, I've been really lucky. I've never experienced sexual harassment. And then I showed them the examples I just showed you. And they said to me, oh, yeah, that's, of course, yeah, that's just normal interaction. That's just every day. But I haven't ever been harassed. So this interaction is so pervasive that we don't even notice it when it happens to us or it's happening amongst us. Definitions. Most people are not going to go and read the definitions of sexual harassment and sexual assault, but actually they're really important to know. And as you read them carefully, you might realize that, yes, absolutely, you've witnessed sexual harassment or even sexual assault. But even more disturbingly, you might realize that you have experienced sexual harassment or even assault, or even more uncomfortably, you might be the person who has perhaps said something inappropriate or done something inappropriate, intentionally or otherwise. And bias absolutely affects men as much as women. It doesn't matter what your gender is. And if you look at this photo, common thoughts in this photo are, oh, that woman, she was totally up for a good time. She's blonde. Look at how low her shirt was unbuttoned. She's got a really high slit in her skirt. She was totally asking for it, wasn't she? And how many people are looking at this photo and thinking that the woman is the boss? So then it brings us to some work I did with a research group. And you can't help but notice and wonder if these biases that we've just talked to, how much they do pervade our society, but also perhaps do they pervade our regulatory systems? So look at this headline, doctor not struck off by panel for one-off rape. Now, if you read the tribunal transcript for this, like I have, him not being erased was justified by the fact that it was a one-off rape, but also justified by the fact that he had testimonials of good and high clinical competence. And I'm hoping most of you will think, well, his clinical competence has got nothing to do with the fact that he actually was proven to be a rapist. And then we have this case where a doctor was suspended and not erased for a sexual relationship he started with a teen whom he met at 13 as a patient and continued to message her until she was 17 when he started a sexual relationship with her. We, of course, then have the Oxford transplant surgeon who was suspended, not erased, for 8 months of sexual harassment, again spanning over a decade, multiple targets. But then we have in the same hospital, this trust, a doctor who was sexually harassed 3 women, he was erased. So I think you can see that there's a theme of perhaps, maybe, I hope you will feel, leniency and inconsistency. So we set out to look at these cases in an objective manner and see, are these outliers, or do they really represent the decision-making of medical practitioner tribunals? And that resulted in these 2 publications, which came out literally, I think, a month ago, and they were joint press releases with a unique collaboration with the BMJ and the Royal College of Surgeons Bulletin. And the press coverage was a bit of a surprise, or it wasn't a surprise actually, because it was such a controversial and important thing to be highlighting. But we found ourselves doing interviews with Channel 4, The Guardian, The Observer, Independent, BBC News, Sky Radio, Women's Hour, and I'm new to the altmetric score, but the chief of publishing for the Royal College emailed me to say, your work has an altmetric score, which is apparently in the top 5% of all research outputs. So the impact of this work was massive. And to tell you about it, I need to tell you a little bit about the GMC and the NPTS. So the General Medical Council, as you all know, is our regulatory body, and they fund the NPTS, but the NPTS is an independent decision maker to the GMC. So the GMC, if there's concerns about a doctor and they're referred to the GMC will conduct an investigation. And if they feel that that doctor could be impaired, they will refer them to a fitness to practice hearing. Okay, and that fitness to practice hearing has 3 stages to it. One is the finding of facts, where the panel, which consists of 3 people, one is a legally qualified chair, one is a medically qualified chair, and one is a lay person. So just 3 people. And they will spend some time looking at the allegations and decide on the basis of balance of probabilities whether they think the allegations are true or not. If they feel that they are not proven and not true, then the case is closed. If they feel that the allegations are proven, the tribunal moves on to stage 2, which is thinking about impairment. And they then start to consider if that doctor possibly is impaired to practice. If they don't think they're impaired despite proven allegations, the case is closed. If they feel that they are impaired, it will move on to stage 3, where they then consider sanction. And the way they consider sanction is by using the NPTS sanctions guidance framework. And that guides panel members into thinking about the allegations, the impairment, and mitigating factors which would lessen sanction, and aggravating factors which would increase sanction. And the sanctions can lead to no action. Those decisions can lead to no action at all. They can lead to conditions which can be imposed for up to 3 years. A doctor can be suspended for a maximum of 1 year, or they can be erased, which is for a minimum of 5 years, after which they can reapply to be on the register. And it's important to note that cases are brought to the hearing by the GMC versus the doctor. So it's not going to be the victim versus the doctor, it's the GMC versus the doctor. So we looked at 1 year's worth of tribunal outcomes, and we were looking specifically at sanction. The MTS tribunal transcripts are publicly available for 1 year only, which is why we did a year. In that year, the GMC published that 10,000 doctors had been referred to the GMC. And of those, 222 were referred to fitness to practice hearings, so thought that they may be impaired. And of those, 55 cases involved sexual misconduct. Now, we wanted to look specifically at sanction outcome. And of the 55, 9 had allegations that were not proven by the tribunal panel. And we didn't feel it was within the scope of our study to judge whether their judgments of the allegations were correct or not. But it was interesting to note that all 9 of those cases had legal representation. So we were left with 46 tribunal transcripts where the allegations were proven, and we looked at those and the demographics of those. So 15 of those had criminal convictions, and 31 were sexual misconduct without conviction. Interestingly, all 46 were male. Now, they didn't publish ethnicity, so we looked at whether they were a UK graduate or an international medical graduate, and there was no difference in the country of graduation. What was really striking and really difficult for us reading those tribunal transcripts was the nature of the offences. So there were 4 rapes or assaults by penetration, which is the definition of rape. There were 25 associated assaults, 5 harassments, and 12 cases of offences against children. And personally, I found it really difficult to read these. You kind of think you have a job to do. I think, well, I'm going to put aside this afternoon to read tribunal transcripts. And I found that I could only read for about an hour, and then I'd have to walk away take some time, and it took me some time to get through the tribunal's transcripts that I had been assigned to me. And each one was double verified by another co-researcher. We go on to look at more of the demographics. The group and the specialties that were represented most were GPs and unfortunately surgeons. A lot of us in this room are surgeons, but they were all also represented across the board by all medical specialties, so medics, psychiatrists, emergency medics, but basically across the board. And then if we look at seniority, interestingly, there was a mean of nearly 25 years since graduation. So a lot of these people were quite senior along in their careers. And actually, if you looked at their grade, registrar, post-CCT consultant, and GP, 83% were in a senior role, which commands a level of authority over others in a hierarchy. And 22% had additional leadership roles. So roles on national committees, educational roles, management roles. So really what we're seeing is a theme of abuse of power. So I'm going to talk first about what we found, and we'll talk first about the pie, and that is leniency. So as I said, the GMC bring a case against the doctor to the tribunal, which makes an independent decision. But what they do is the GMC legal team will propose what they feel is an appropriate sanction. And in nearly a quarter, 24%, the MPTS determined a sanction that was less severe than that proposed by the GMC. So in that quarter, all of those cases, erasure was proposed, and the GMC determined suspension and not erasure. And it was never the other way around. It was never that the GMC proposed suspension and the MPTS determined suspension. So there was actually a tendency towards leniency. And then if we look, what we did is we looked at the factors leading, or the factors that were more likely to lead to being either suspended or erased. And you'd be relieved to know that if there were offences against children, pretty much across the board, that resulted in erasure. Thank goodness. But whilst the majority of cases where there was a criminal conviction also resulted in erasure, there were at least a couple, or one case at least, where the doctor was registered on the sex offenders register and allowed to return to practice as a doctor. We look at factors more likely to lead to suspension. It's showing evidence of remediation, expressions of regret, demonstration of insight, and things that made no difference at all is abuse of power or position, and the number of targets or the number of incidents made no difference at all to your sanction. But if you look at that sanctions guidance in more detail, and if you look at some of these tribunal transcripts, there is no definition for what constitutes adequate remediation. The threshold of remediation is not defined at all. And if you read this, this is the case of the doctor who essentially messaged that 13-year-old for many years until he started a sexual relationship with her. And look at what was counted towards remediation: an advanced trauma life support course, and compliance with Irish Medical Council CPD requirements, so basic requirements for professional development. Nothing to do with sexual misconduct remediation. And the other thing that's quite disturbing is there are commercial entities and barristers, teams of barristers, who will absolutely coach you to demonstrate remediation, insight, and remorse. And this is one commercial entity, and it's quoted literally on its website. It says, "The way a doctor responds to a fitness to practice concern can influence the outcome of their investigation. The right response can lead to less severe sanctions, and in some cases, no sanctions being imposed. And we look specifically at insight and remediation and how both of these can lead to better outcomes." And we all know, as training doctors, right from medical school, we are trained to tick boxes for portfolios. These are very easy boxes to tick. So we looked at the sanctions guidance a little bit more detail to figure out how these decisions were being made, and there were some key flaws that we felt were in there. So one key element is that you have to prove sexual motivation. And for us, that's troublesome because we know that in a lot of cases of sexual harassment or even sexual assault, this is an assertion of power. It's a tool to devalue and humiliate. It's not about sex, it's about power. The GMC itself recognised that a lot of these cases have delayed reporting because of fear of retribution, being vulnerable, fear of scrutiny. But the NPTS guidance has delayed reporting as a mitigating factor, so a fact that would lessen sanction. So that's completely discordant. Aggravating factors such as coercion, grooming, manipulation, persistent patterns of behaviour, and most disturbingly, events and sexual harassment or misconduct that is occurring during patient episodes of care are not recognised as aggravating factors within the sanctions guidance. So even if the tribunal panel on a personal level were to recognise these things, they cannot factor it into their decision making in a formal way. And lastly, definitions. The definitions I just showed you, if you don't have training and understanding of what the definitions are, you're not going to be able to recognise behaviours. And in fact, there was a case in 2019 of the GMC versus Harris, and that doctor performed intimate examinations on 2 women, genital examinations and breast examinations. And if you read the tribunal transcript, it's all about the fact that he didn't take medical consent for those examinations and whether the examinations were necessary or not. There is no mention at all in that tribunal transcript or recognition that actually this represents assault by penetration, which is the definition of rape. So if you're not adequately educated, you're not going to even recognise what's happening. And lastly, we did interviews with victim witnesses, and there was minimal support and absolutely no advocacy. The cross-examination at the tribunals was aggressive. They were isolated. There were many interruptions. Sometimes the interruptions meant that they had to stay unexpectedly overnight, isolated in a hotel, and continue being cross-examined the next day. And there's very little recognition that if you are vulnerable, you're not going to be able to interpret questions or answer questions optimally. So the new NPTS guidance actually was published last week. Luckily, they did go to consultation in May, and I was very lucky to be invited to that consultation by the Royal College of Surgeons. And at that point, we had the data, but we hadn't put it together yet. So some of these points I was able to put to them, and certainly were put to them. There have been some positive changes, especially the recognition that colleagues, like patients, are members of the public and can be vulnerable and also deserve protection. Testimonials will have limited value in sexual misconduct cases now, and that behaviour is not always sexually motivated. However, aggravating factors such as coercion, manipulation, repeated behaviours, and misconduct during patient care are still not defined and recognised. And so, of course, we're going to repeat the study. These new guidance is going to be implemented in 4 weeks' time. So the message for you all is to watch this space, and we'll let you know if it's made a difference. Thank you.
Invited international speaker. So Jason Harley is a tenured associate professor in the Department of Surgery at the Faculty of Medicine at McGill University. And he's also a scientist at the Research Institute of the McGill University Health Centre, Director of Research at the Steinberg Centre for Simulation and Interactive Learning, and Director of the SAILS Lab, which is Simulation, Affect, Innovation, Learning and Surgery. Their research themes aim to enhance surgical and health professionals' education and support healthcare workers by reducing adverse events and inefficiencies, especially focusing on those associated with the incidence of undesirable and unregulated emotions, burnout, and in this context, especially harassment. So their talk, as you can see, is leveraging simulation and educational videos to equip medical residents with the tools to combat harassment. Thank you, Jason, so much.
Good morning, everyone. Thanks so much for coming. I will jump right into things. So I don't have any relevant disclosures to make. I like to start off with a land acknowledgement. The McGill University, where this research was conducted, is on land which has long served as a site of meeting and exchange amongst Indigenous peoples, including the Haudenosaunee and Anishinaabe nations. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which the peoples of the world now gather. We've got a good amount to get through. I'm going to skim over, I think, most of the research but I'll be happy to take questions after, and I'll be staying around here for a little while after, so very happy to take questions. A lot of the research is published already as well. What is harassment? So Ms. Nortley had a wonderful presentation, and I really thank her for that. We look at, in my lab, harassment as a broader construct that includes other forms of harassment. Our Royal College of Physicians and Surgeons of Canada defines harassment as unwanted physical or verbal actions that offend or humiliate. And while it's acknowledged that typically harassment is something that takes place when it occurs repeatedly, a serious incident can also qualify as harassment. This is an imperfect definition, but it's a good starting point to especially appreciate the breadth and some of the features of harassment. We're particularly concerned about harassment in surgery because it has a higher incidence compared to other medical disciplines, as we saw from Ms. Nortley's talk. This can lead to poor physical and psychological well-being, impaired professional development, and in the case of medical students, for example, people choosing to go into other programs, amongst other negative implications. It's hard, and a lot of people, as was also pointed out, there's a lot of bystander observation that goes on for a lot of reasons. People don't necessarily feel prepared or ready to respond. They don't necessarily know how. That combined with concerns around hierarchy, vested interests, can lead to a culture of silence. Most bystander and anti-harassment training typically relies on lower and passive forms, such as lectures and videos. This leads to limited engagement and effectiveness, and there hasn't been a lot of strong evidence that these forms really have the results that we're hoping for. Recently, and actually fairly concurrently, a couple of research groups, including ourselves, seem to have all gotten the same idea around a few years ago to try to use simulation to try to do something about harassment. We all got started to get published around December 2024. In our case, January 2025. So there's a very tiny emerging literature on this, which my team is very happy to be part of. We know for those of you who are familiar with simulation, and at least from your own training, simulation is great because it gives us hands-on practice. In a context that's standardized, controlled, there's no patients to be concerned about in this case. It gives us opportunities to do more we can to secure psychological safety. Prior simulation research has tended to be based on one-off educational interventions. One of the unique features of our program of research is that it's really both educational, it's an educational intervention, and it's a program of research where we collect everything from psychophysiological data to self-report and video, and qualitative data from coding of the videos to debriefings afterwards. And we've been doing this since about 2022. So it's a long-term program, and I've secured funding internally and externally to keep this going for at least the next 5 years, which is unique as far as educational research typically goes. Our work is also more psychologically safe on average due to a number of measures we have, and we bring a lot more analysis to the table. Some of the key frameworks that we use is the 5-step cognitive process. As a psychologist, this certainly psychological models are always a nice thing to have. Generally, there's four precedents or antecedents that someone's going to need before they're going to take action with harassment. They need to first notice a specific behavior, to acknowledge the behavior as harassment, so to acknowledge that it's inappropriate, to assume personal responsibility for it, and then, of course, to know how to help, and then to hopefully feel some level of comfort, and that's where they're going to intervene. We also used 4 bystanders, or the four Ds. These can include being direct, so this could be something like calling someone out, mentioning that the way someone is treating someone else makes them uncomfortable or is uncomfortable for the other person. Distract, so less direct. This could be to redirect the conversation, make a joke so that stops, at least for the time being. To delegate, to appeal to someone else who may be in the room, or maybe someone who can be called in, or approaching someone later to take charge, perhaps someone with more authority. And finally, delay. So after the fact, speaking with the victim, making sure they know what their options are in terms of reporting, displaying empathy, etc. So these are some of the things we train people to do. Our intervention is 2 parts. We developed in-house videos that take people through what is harassment, what kinds of ways they have at their disposal to take action, including the 4Ds, how to go about reporting in their institutional context. Our target population are medical residents, especially in surgery and internal medicine. So we review McGill's and as well as our McGill University Health Center. That's our hospital network, and what the rules are there and the opportunities. And we provide them with some example scenarios to bring these things to life. I just took some screenshots. These are, again, animated, and they just give you an idea of, very briefly, I'll go through them, of what kind of this looks like. It's always helpful to have some movement and engagement. Our second part are simulations. The 3 people here are former students. So there's a harassment event. In our case, the only person who is not a standardized participant is the junior resident. These are typically year 1 for all surgery as part of their surgery foundation OSCE, or their year 1 or 2 for internal medicine, depending on the year and program. So we have them, they're doing a central line insertion. We have someone playing the role of senior resident who berates the medical student. Again, the medical student is also a standardized participant. And as the harassment unfolds, it starts off as the senior resident just being grumpy, the medical student is late, and this proceeds to more direct and escalated harassment, where they say things like, "You're so stupid, you should be in a museum." One of the things we did to help ensure psychological safety, especially as there had been no prior research looking into this sort of an approach to deal with harassment, was we ensured there was no discriminatory language, sexist language, etc. involved. So we kept this on the modest side. But our findings showed that this was certainly enough. We also conducted debriefings afterwards. This is both for debriefing is a really important part of simulation. It's a chance to reflect and process what took place. As I mentioned, we've got a lot of psychological safety measures in place, including following the healthcare simulation standards of best practice. That is the Society for Simulation in Healthcare's guidelines. We did a lot of consulting with associate deans, program directors, medical residents, simulationists to make sure this got right. We went through an iterative development process. We, of course, followed our IRB. As I said, there's no discriminatory or sexual forms of harassment. Residents also knew in advance that there would be a station where there would be harassment taking place. And this thing ended on a positive part. I'm going to really blow through the research quickly. Our first study has been published in Simulation in Healthcare. We looked at learning sequence. We wanted to make sure, because residents' time is so precious, that if we were showing them a video, that this actually helped when it came time for them to do the simulation training. And unsurprisingly, we found that it actually did. So for those who watched the video first, then did the simulation rather than the other way around, those people scored higher in terms of the behaviors they actually engaged in during the simulation. In other words, they did a better job with intervening behaviorally when harassment behaviors occurred in the simulation. We found similar results recently with self-reported motivation. So people were also more motivated or reported being more motivated to deal with harassment once they watched the video first. Another former master's student, Nagar Matin, did work psychophysiologically. And so here we were interested in seeing whether or not, first of all, we found that there were differences psychophysiologically between before and after harassment took place. And this helped give us, to an extent, kind of some validity evidence that this harassment scenario was something that was emotionally activating. And that was something we saw as we anticipated. We have another article that's been published in the Journal of Surgical Education by another former master's student, Miriam Johnson. I'm just going to run through very briefly. I'm going to come to this actually probably in the discussion slides. I think that's the fastest way for me to cover it. Here we were interested in looking at characterizing the behaviors that medical residents, in this case surgical residents, deployed. And we looked at capturing this and modeling this over time as well. So as you see, passive responses were quite common the whole way through, especially educational responses. But there were also some responses that are less ideal, especially for people who've been trained. This is the second study, so all people went and watched the video first in this case before doing the simulation. So we still saw a lot of avoided responses, as well as unreactivity in some cases. We saw with regards to our medical student-centered responses that as soon as the senior resident had stormed off, that was part of the script, that at that point, that's where people are more comfortable jumping in and educating the medical student, speaking more with them about how inappropriate the behavior was. And with our senior resident responses, these ticked up as the harassment escalated. People were more willing to do things like have a direct response, for example. This was in some cases, though, often something like distract. It was a minority of people who were comfortable mentioning that something was really inappropriate. I'm going to cover this through, in the interest of time, just a discussion. So again, we saw that passive responses were much more frequent, and actually statistically significantly more frequent than all other behaviors throughout the simulation, especially in response to harassment. This is notable because, think about it, this is a simulation. This is not happening in a clinical environment. And yet, even with the knowledge that this is a simulation, with training for how to deal with a simulation, there were still a lot of passive responses. And we also noted, as we do in the article, that there were cases too of the senior resident siding sometimes with or the junior resident siding with the senior resident in some cases. People talked about in their debriefings why. Again, despite the fact it was a simulation, people cited hierarchy, fear of retaliation, and uncertainty about addressing the situation. So there's still work to do. We saw, it's not surprising that we saw little in terms of direct responses, and we don't think it'd be practical for residents to leave a simulation and be prepared to go and be confrontational with, even in a professional way. Perhaps with attendings, with senior residents because of hierarchical concerns, but we would like to see more, ideally in terms of distract and other kinds of behaviors that really don't conflict as much with hierarchy. In terms of our passive responses, again, we saw a lot of education. That was one of the most common ones, where people tried to focus on the procedure rather than what was going on. There was also not a lot of focus in terms of reporting, even after the person left the room. We've got a lot of research directions. I'd be happy to take questions about those. I did want to make time for what you can do right now with some of the stuff we've developed. There's two things basically that I'd like you to take away from this morning. One is that you can implement our anti-harassment simulation in your centers if that's something of interest. Our script is published online and open access, and I'm going to send you to a QR code in a minute. You can also review your institution's anti-harassment policy or policies. We've recently published also a policy analysis where we looked at all of Canada's medical schools' policies concerning harassment, as well as the top QS ranked universities, and essentially created a method of evaluating them to see, are there some places that are not clear, that are missing, etc. So this is the QR code for those of you who might be interested. This is on Zenodo, or Zenodo. This is actually the same open access framework that CERN, the particle accelerator, uses. And after having visited CERN a couple of years ago in Switzerland, it's a nice association. So this is here. There's also more details on psychological safety. The debriefing script is also here. So again, if folks want to use this, I'd be happy to take questions. If you look through the script and you're like, oh, how does X work? Please send me an email. Similarly, our policy evaluation tool is also available here. This was published in the Canadian Medical Education Journal and was actually selected as one of their top articles of 2025. And I'll be presenting this at the International Conference on Academic Medicine in Ottawa in a special section this spring. I want to acknowledge my wonderful team in my lab, as well as the valuable surgeons, internalists, and others that I work with that help make this research possible, in addition to our funders. Thanks so much for listening. I will be around for a few minutes after. I know that it's a couple minutes after 9, so I want to let people go, and certainly also take questions if there are any. Thanks so much for your attention and thoughts.